But indeed, there is measures that we can do at bedside where we can look at, do these patients have nerve involvement?
Back in 1998, the Quebec task force gave us a way to classify whiplash-associated disorders. And for decades, grade 2 has been treated just as a musculoskeletal issue, neck pain, stiffness, and maybe some limited movement. But what if that's not the whole picture? In today's episodes, we're joined by Dr. Annina Schmid and Dr. Joel Fundaun, two researchers whose work is challenging that traditional view. Their research shows that many of these patients are actually dealing with nerve-related issues, and the best part? These signs are detectable with simple exams you can start doing in clinic immediately. Before we dive in, make sure to subscribe so you don't miss future episodes, and if this one sparks new thinking, share it with a colleague who needs to hear it. Stick around to the end where we unpack simple, clinic-ready tools that could change how you assess and treat whiplash starting tomorrow. Let's get into it.
This is the Modern Pain Podcast with Mark Cargila.
Annina, I wanted to start with you today. Glad to have you and Joel on the podcast. I really have enjoyed your work, both your works as you've published recently on whiplash-associated disorders. Before we get into the details of that, I'm wondering if you could introduce yourself and a little bit about the lab that you kind of run there in Oxford.
So my name is Annina. I'm a physiotherapist by training, and I did my musculoskeletal kind of specialization in Australia, then a PhD in Australia, and then moved to Oxford quite a while back now, 13 or so years back. And so in Oxford, I'm leading a team called the Neuromusculoskeletal Health and Science Lab, and we are a bunch of really nice people, I have to say, but I'm biased, of people looking at neuropathic pain specifically, but also nerve injuries and certain musculoskeletal conditions that might or might not include a nerve injury. Obviously, me being a physiotherapist, we still have somewhat a physio focus. So we are also interested in physiotherapeutic interventions for people with nerve injuries and neuropathic pain. But we also have a focus that is much more neuroscience based. So we are looking at the mechanisms of nerve injury, the mechanisms of nerve regeneration, the mechanisms of neuropathic pain specifically. And we use a translational approach, for example, combining biosample analysis from humans, including nerves, skin, blood, etc., with clinical phenotypes in patients as well. And so that we can get an understanding of what exactly is happening when people have a nerve injury or neuropathic pain.
Joel, I wonder if you could discuss your development and how your paths cross with Annina, obviously with your PhD and where you're at now.
So I was working clinically as a physical therapist in the US. I had completed my residency in orthopedics at Northwestern and Shirley Ryan Ability Lab. And from there, I was treating many patients that had whiplash injury and was especially interested in that subgroup that had nerve-related symptoms or neuropathic symptoms that just didn't make sense and were much harder to treat. And so then it was after my residency that I realized that I did want to do a PhD. So I reached out to Annina. Her work has for a long time shown physiotherapeutic ways that we can intervene in different neuropathic conditions as well as different mechanisms related to those. So I was very interested in trying to understand whiplash from that perspective. So then I was very fortunate to get to do my PhD with Annina, focused on this project that we'll talk about today, further looking at whiplash and nerve-related conditions. And now I'm trying to continue some of that work here as a postdoc at Stanford. And I continue to work clinically as well as a physical therapist.
So you've been not doing much since graduation after school. That's a pretty impressive journey to go from Oxford to Stanford postdoc. That's amazing. So kudos to you for that. Some of the things that kind of laid the groundwork for some of your work was the systematic review you all did in 2022 that kind of looked at the presence of neuropathic or nerve symptoms, because it was thought, maybe you can get a little bit into kind of the staging of whiplash-associated disorders that's used out there and how maybe traditionally it was looked at and how your study or your systematic review kind of questions some of the maybe traditional categorization of whiplash-associated disorders.
The whiplash-associated disorders is a term that's been used for a very long time. The Quebec task force grading system has been developed since the 90s to try to find a clinical approach to help us understand this very heterogeneous and complex condition. So they group it into kind of 5 levels, from 0 to having kind of no pains or problems to 4, which is the most severe, where someone would have a fracture or dislocation of their neck. And most people from the literature fall into whiplash grade 2. So that's neck pain and musculoskeletal signs, so reduced neck range of motion or stiffness, but they don't have frank neurological deficits. So that'd be reductions in light touch, in strength, or reflexes. But since that grading system has come out, basically ever since then, there's been pushback about how complex this Whiplash grade 2 is and how heterogeneous even that group is. And we were interested in that because that's what we see clinically as well, and what the kind of more research in the past has led to. So that's what led us to do the systematic review, to try to look at all of the literature that's currently out there to see what is present.
Annina, I'm wondering if you could talk about how that question arose in your work in your lab, as far as what kind of led you all to start looking into this from what you've been seeing as you've been studying Whiplash.
Yeah, absolutely. It's very similar to what Joel said. My spark into Whiplash was started in my clinical practice when, at that time in the UK, we were still seeing these patients mainly coming through insurance claims, and then they had to go and have physio so that the insurance claim could go through. So that has since changed. But at that time, we were seeing a lot of patients with Whiplash-associated disorder in private practice. And to me, it just became clear that some of these patients have something else than just tenderness or just a bit of neck stiffness, what we consider truly musculoskeletal kind of problem. When you listen to them and you examine them a bit more carefully, you often found symptoms of neuropathic pain, things that cannot truly be attributed to, say, a muscle problem or maybe a facet joint, or maybe also not just to fear of what has happened to you during an injury. So I remember when the World Physio Congress was in Singapore, I can't remember, was it like 2016 maybe or so? That is when I contacted Michelle Sterling, who I knew from Australia. I did my PhD in the same department that Michelle Sterling was in Australia. And I told her we really should look at Whiplash at some point, because my work has mainly focused on nerve injuries. And I was discovering that a lot of these people with minor nerve injuries, like compression neuropathies, etc., they seem to have deficits and structural changes to small fibers dominantly in their nervous system, before we even see frank lesions to the large fibers on, say, standard bedside neurological testing or electrodiagnostic testing. So I was observing the same thing in clinics with these patients. And with Michelle Sterling, and so that was led by Scott Farrell, who was a postdoc, or is still a postdoc in Michelle's lab, we did a study in patients with chronic whiplash-associated disorders. And we showed that in patients with chronic whiplash, so these were patients who had 5 years or so of symptoms and have not recovered, so these were all non-recovered patients, we did show that these patients did have changes to the small fibers in the skin. They also had changes to sensory changes that suggested something is happening with the nervous system. So that was quite intriguing at that time. But obviously, the question that this paper couldn't answer was this something just secondary, potentially due to long-standing changes, long-standing inflammatory responses, for example, in these people, inactivity over time in patients who have chronic symptoms? Or was that indeed something that happens acutely related to the whiplash injury rather than develops later as a consequence of chronic pain? So for that reason, we were quite interested to set up a longitudinal study. And I was lucky at that point that Andrew Dilley, who is a researcher in Brighton, he got in touch and wanted to do a study as well, looking at neuroinflammation in these patients using MRI. And so we combined forces, basically, and we're lucky enough to get some funding to do a longitudinal study to look at whiplash injury from the acute stages to the more chronic stages. That's how it came about.
There's a paper this year recently, that a couple that have come out recently in the last year or so, with the evidence for peripheral neuroinflammation. I know Colette Reidhall had led that paper. I'm wondering if you could speak to that. Joel, I know you were second author on the paper. I'm wondering if you could speak to a little bit of what y'all found when you were looking at that, as how that study was set up and what kind of findings were.
So this was led by Colette, but this is importantly all from the same group of people. So working with Colette and Andrew and our other collaborators, this was one focus of our project, and that was looking at signs of neuroinflammation. So when participants came, they were within a month of their injury, so within 4 weeks of having their whiplash injury. And then we track them over time and do another assessment 6 months later. So this paper is looking at signs of neuroinflammation using MRI, so a specific type of MRI scan that we can look at the dorsal root ganglia and the brachial plexus. And then we did a host of other measures to look at inflammation as well. Serum, so blood markers of inflammation. We compared that from the Whiplash group to participants who were just healthy non-pain controls. And then we also looked at many other clinical measures that included a typical clinical examination, just like we do in the clinics ourselves. We looked at signs of nerve mechanosensitivity, so upper limb neurodynamic tests, palpation pressure to certain nerves over the brachial plexus and throughout the arm. And so we tried to use all of those as clinical correlates or like composite scores that we might be able to do to classify if some of these patients acutely after whiplash injury did have signs of neuroinflammation.
Yeah, and some of these tests are obviously in a research setting work wonderfully in MRIs and all that things. And a lot of the tests you talk about neurodynamics and palpatory exams and things like that. I'm wondering if you can distill that down a little bit for the clinician on the front line, as far as obviously some of that technology out of reach for most of us, but obviously there's ways we can assess this in our patients that we're seeing who are dealing with whiplash. I'm wondering if you could speak to either of you as far as what kind of neurodynamics, I got to imagine being one of them. What other kind of modes can we start assessing this to get an understanding of this if we're assessing somebody who might have whiplash associated, that's categorized as type 2, where we're determining how much nerve involvement is present?
We did actually quite a lot of different tests, and we should probably highlight these two papers that I've just recently published. Like Joel said, these are part of the same cohort, but looking at slightly different aspects: neuroinflammation versus nerve pathology, which we classify more with loss of function, so actual nerve, structural or functional nerve deficits. So we purposely did combine really heavily research-based methods, like you say, advanced neuroimaging, as like serum inflammatory markers, skin biopsies, etc., blood markers of axonal damage. But we also combined this with simple clinical measures that we can use in clinics. And the idea behind that is obviously all of us coming from a clinical field, that is interesting. So we find these kind of changes in patients with whiplash grade 2 across the board, not just in the very sensitive kind of research measures, but also in some clinical measures. So a simple kind of thing is, if we use the neuropathic pain grading scale, which is a grading system that has been described by Nana Finnerup, where we basically can decide the certainty that somebody has neuropathic pain, we did find that about 65% of patients are classified as having possible or probable neuropathic pain using this very simple clinical grading system. We also showed that simple bedside testing of neurological bedside testing, including light touch, muscle strength, pinprick thermal tests, reflexes, does show changes in quite a substantial proportion of patients. About 50% of patients, 54% of patients, I believe it was, had sensory deficits on a neurological examination. And again, we showed that the main test to show that was the small fiber testing. So this is mainly thermal and pinprick sensations that showed these changes more sensitively than, say, large fiber testing like motor dysfunction, reflex testing, or light touch testing. And then the neurodynamic tests, we use them as a proxy for neuroinflammation. The reason behind that is coming from preclinical work where Andrew Dilley and his team has shown if you inflame a nerve artificially in an animal model, the nerve becomes sensitive to pressure and stretch, which is basically what we're doing in a neurodynamic test. So we put tension on the nervous system, or if we palpate, we put pressure over the nervous system. So if we can extrapolate from, say, from preclinical work, we would expect that if there is neuroinflammation, that's quite likely that nerve might be sensitive to tension or to pressure. So this is why we use those neurodynamic tests and the nerve palpation as well. And indeed, again, we did find about 55% of patients had positive neurodynamic tests that we can detect in clinics. So there was not always perfect overlap, I should say, between these different measures. And we also believe these measures partly measure probably different things of nerve health as well. But indeed, there is measures that we can do at bedside where we can look at, do these patients have nerve involvement?
So I'd also, just to reemphasize what I mentioned earlier, but the group of people that we looked at after whiplash injury were all classified as grade 2. So we wanted to take a really in-depth approach that Annina just mentioned to look at nerve health in many different ways, because clinically we did suspect, and previous literature has also supported, that a subgroup of these patients do have signs of neuropathic pain or nerve involvement. And so this whole group was classified in that way. So I think that that's important to highlight some of the context of what we're talking about. But like Annina mentioned, all of us had been working clinically and also didn't want to just do the big, fancy, expensive research methods, but we also wanted to see if there was clinical tools or something that we could take away in our clinical practice that might be important. And so, like she mentioned, one of them was, a main aim of this project was to see if there's any measures that we could take within that acute or about 1 month time point, to see if any of those measures could predict who goes on to develop more persistent or chronic pain. We know from the literature that there are a few markers, those that have really high neck-related disability or NDI scores acutely, those that are older, and those that have kind of signs of post-traumatic stress or hyperarousal. Those have been linked to be associated with worse outcomes as well. But the evidence on this is fairly mixed, and we don't know exact confidence of how strongly we can rely on some of those factors. So one of our aims was to see, can we look at other factors that haven't been looked at before? And one of those that our paper discusses is looking at hypoesthesia, so signs of loss of sensory function. So this was only from the clinical examination, like we mentioned before, strength, light touch, reflexes, pinprick, and thermal sensations. And then we just lumped those together into composite scores of how many measures of loss of function that someone would have. And we did find that the more signs of loss of function that a participant had acutely, so within that 1 month period, was able to predict at least some portion of their pain scores 6 months later. We looked at many other different measures, and this was one of the strongest that kind of came through in our data. And so as we talk about, this needs to be further validated. It's not the end all be all of measures that if you have hypoesthesia or loss of function, you know with full certainty that you will have chronic pain later on. But it's still an exciting clinical tool that we can further look at and try to better understand, that might help us explain who would go on to develop more persistent symptoms.
I'm wondering if you can speak to a little bit of, because I've both been out in the profession a bit and have seen maybe the management of these patients evolve over time to where now with our understanding of more neuropathic components, neurogenic components of their condition, I'm wondering if you could speak to how you've seen the progression of how we maybe manage these patients change over time, and maybe how our current data with all the great work you're both doing might influence how we might manage these folks moving forward.
Yeah, exactly. Whiplash is quite an interesting condition, and obviously a relatively new condition also, because road traffic accidents are obviously, we haven't been driving for so long, and other types of whiplash have been rare, and probably more horse-related injuries in ancient times, etc. But whiplash has received a bit of a stigma, right, over time, especially in regards to malingering. There have been some landmark papers suggesting that, for example, litigation plays a role in terms of chronicity of whiplash. But these papers have actually attracted quite a lot of criticism in recent years. And there is, at the moment, no clear indication that litigation or compensation claims, open compensation claims, etc., have a clear prognostic role and predict clearly who develops chronic pain or not. But of course, this has led to a bit of a stigmatization of patients, right? In terms of malingering, are they really telling the truth? Or is it mainly psychological problem as well that patients have? And of course, all of us know, even if you just fall off your bicycle without an injury or somebody hitting you, it shakes you, right? It will lead to feeling a bit stressed, or in some patients, this is clearly apparent that they do have symptoms that are going towards post-traumatic stress, for example, etc. So that is probably not a surprise. Now, if we look at treatment in these patients, there is quite a lot of literature on that. And if we summarize the literature, probably simplified, we can say that there is some effects for, say, therapeutic interventions, so physiotherapeutic interventions, for example, for people with whiplash, but the effect sizes are very small. At best, very small. And that includes usually exercise-based programs, but that also includes programs that involve psychologically informed care, behavioral type approaches as well. All of them, if any effect, it's very small effects. Now, if we think about, do some of these patients with whiplash grade 2 have neuropathic pain, then technically we should think about, should we potentially provide treatments that are targeting neuropathic pain? And again, if we look in the literature, there's hardly anything on neuropathic pain treatments in these patients. In fact, guidelines at the moment in the UK, for example, suggest we should not be given these patients, for example, neuropathic pain type medications. So it's even indicated that we shouldn't do that. In our cohort of patients, if I remember correctly, one of the 129 or so patients had a first-line neuropathic pain medication, even though about 60% or so had neuropathic pain according to clinical grading. So one could argue maybe these patients are somewhat undertreated on the neuropathic pain side of things. And there are two very small feasibility and pilot studies that have been done, one in Australia, one in the US, where they looked at giving neuropathic pain drugs, like one is duloxetine and one was pregabalin, to patients with whiplash injury acutely in A&E. And both of these studies show quite promising effects, but they're obviously heavily underpowered. And I know in Australia, for example, there is an effort underway at the moment to look at to do the larger trial, giving pregabalin acutely to patients who had a whiplash injury to see whether indeed that might prevent persistent pain in these people. So that is one aspect, but we could also think in terms of physiotherapeutic interventions, if you don't want to go down the pharmacology side of things. There is actually, to my knowledge, and correct me if I'm wrong, Joel, but there's not much data at all about, say, for example, neurodynamic interventions. Despite about 55% of patients having positive neurodynamic tests, and from the literature, we know in spine-related leg pain, spine-related arm pain, we know those that have positive neurodynamic tests are the ones that seem to benefit more from these kind of treatments. But it hasn't really been studied in that population, and very likely not been studied dominantly because it's usually considered a musculoskeletal condition. So I believe we probably have to rethink that a bit. At the moment, we do not have good large-scale trials to suggest that this is what we should be doing. I think as researchers, we should look at that as an option.
Sounds like another PhD opportunity, maybe through the lab to start studying some of those things. Joel, what's your thoughts on that too, as far as obviously you both have a good physiotherapy background, as far as with some of these results, what they've been shown with, hey, there's probably some neuropathic components to these patients. We shouldn't just assume it's a strict musculoskeletal issue without considering that. How does that change your approach clinically with those patients? And maybe what research, I know Annina's kind of teed it up a bit, as far as what research needs to be done to help us understand what's maybe the best way to intervene with these folks?
I think one important clinical takeaway that our project and others is trying to say is that even just as a first step as clinicians, oftentimes we're very busy. You see a lot of people. You're trying to do your best to manage all of the expectations and things that you have to handle as a clinician. And even just like some of our quick concepts of whiplash and that person that we're going to see in the clinic, often even just the potential for neuropathic or nerve-related pain isn't really even on our radar. So just to first emphasize that even just in the subjective history in patients that have had traumatic neck pain or whiplash injuries, that just asking about subjective questions about their quality and type of pain. And obviously a lot of clinicians are already doing that, but just really giving someone the opportunity to describe their symptoms well, and that we're just not assuming that because they've had a whiplash injury, it's mostly musculoskeletal. Because even in our research study, when we would discuss this with patients, the predominant symptom that most people have is neck pain. But then when you give them the time and further ask about their symptoms and what they're experiencing, they often point to, yeah, I do experience numbness, or my hands have been tingly since the accident. The pain does radiate or does feel sharp or electric at times, but you don't always get that at first question. And so just incorporating that early on in the subjective in patients with whiplash injury can be very helpful. Annina has a great video describing, we've talked about it quite a few times, but one of the clinical guidelines for grading neuropathic pain is from the Neuropathic Pain Special Interest Group. And that classifies patients on different levels, from unlikely to have neuropathic pain to probable or definite neuropathic pain. And so those classifications require kind of different components. And Annina has a great video that's available on YouTube that describes some of this. But that's one of the first takeaways that I would say some of our work does that could be, that I think about clinically, is that, am I really doing a thorough job in understanding the pain that this person's presenting with? And then the second that we've touched on briefly before is my clinical examination. Again, because we assume most of these patients just have predominant neck pain or stiffness, a lot of times in the busyness of our clinics, we don't always do a full detailed neurological assessment. Our work that we show here, we show that, like Annina mentioned before, acutely, over 2/3 of patients did have signs of loss of function or reduced sensation in that area. But most of those findings came from pinprick or thermal testing. And that's not always something that we consider or do in the clinic. And so, not that every single person should always have a 45-minute neurological assessment, but when people have these signs and are reporting things like this, that a more detailed neurological assessment, including both the large nerve fibers, which would be our typical exam, light touch, strength, and reflexes. It's also important to add in findings of small nerve fiber deficits. So that would be pinprick testing using neurotips or like just a sharp pin, as well as potentially thermal. Annina has done great work validating a clinical tool of this, of just using coins. There's other clinical tools that can very cheaply and quickly test thermal sensation as well. But just making sure that we don't ignore those, because those early changes of pinprick or thermal sensation have been shown in preclinical and clinical studies to show that they can further go on to develop into the bigger problems. And so just acutely making sure that we do a thorough examination is also a second big takeaway from our work in this project.
These are tools that aren't massively hard to come by, a pinprick or a coin or things. I mean, I wonder if you could speak to a little bit about that. I know you've been involved in the Neuropsych working group with kind of classifying neuropathic pain. I mean, I'm looking at the study, spine-related leg pain, but one of the criticisms around like CST that you hear, or QST, that clinicians always, well, I don't have all this equipment. But again, we just spoke to the fact that this doesn't require a lot of major like expenditures. These are things you can put together. I'm wondering what you would recommend as like a clinician toolkit. Joel already spoke to it a bit, but like, what do you think a clinician should have as part of their neurologic examination skill set and toolbox? And maybe how also to determine, what are you hearing that might help somebody say, hey, I maybe need to go into more significant depth in my examination versus maybe more of our kind of base neurologic exam?
Exactly. It's a good question. I probably would do it exactly like what Joel said. So I think it's important to test motor strength, reflexes, and light touch sensation. Obviously, with these ones, you can pick really quite advanced, big deficits that often, let's say, if we go away from Whiplash now, but to say spine-related leg pain, for example, you could potentially pick up very important big neurological deficits that warrant, for example, onward referral, talk about a drop foot, etc. So these things are, of course, very important. But as we said, quite often, especially in entrapment neuropathies, we and others have shown that these small fibers seem to be changed relatively early. And so now one could say, okay, so that's not so important because it might not be meaningful for a referral, etc. But especially if we think about neuropathic pain is actually quite important, because what kind of medications patients are given is dependent on whether we think somebody has neuropathic pain or not. And one part of deciding whether or not somebody has neuropathic pain is a sensory loss. So in a sensory loss, therefore, in a standard neurological examination, and I might be a bit biased because in my clinic, I see mainly patients with nerve problems. But I would always include, as we said, large fibers, light touch, reflexes, muscle strength, but also small fibers, pinprick examination. And if pinprick is normal, then I would move to thermal. And that is because of work that we have done together with Colette Reitholt, where we have shown how the sensitivity specificity works of these tests. That this would be the recommended route. But at least pinprick I would recommend to do in a screening examination in a way. And these kind of, if I do a screening examination in patients, I would say this takes me 3 minutes maximum, but it has potentially quite important implications for if I identify, for example, something is more related to neuropathic pain, that might be important on how I help people make sense of what is happening with them, right? How I explain a neuropathic pain will be completely different to how I explain, say, a muscle pain, for instance. And we already touched on pharmacology, which might be influenced by these kind of things. So I believe it's quite important that people have a relatively comprehensive neurological examination. Let me give you one other reason for that. Is when we test the shoulder, we would also not be happy to just say, okay, somebody has flexion deficit, right? We would probably test many different things around the shoulder. Then we put the puzzle pieces together and we see whether the puzzle pieces fit or not. So if I only have a neurological examination with muscle strength, I have like one puzzle piece, which might well not be enough for me to make sense of it. But if I have many different puzzle pieces and they fit together, that will tell me something. But it will also importantly tell me something if the puzzle pieces don't fit together. So therefore, I think it's slightly risky to rely on a very abbreviated version of a neurological examination. We would also not do that for the shoulder or for the knee, etc.
Makes complete sense. I'm wondering, with my speculative theoretical look at this, because I haven't dug deeply into the literature, but I know there's been some work to show kind of prognostic indicators of how people are going to progress based on some psychosocial things. I'm just wondering where you see this fit, maybe big picture with, because clinically we'll see people who may have this injury, but they have great support. They're financially able to manage this well. They maybe don't have some of the PTSD symptoms and different things. How do you see this? And Joel, maybe you can speak to it as far as maybe a more comprehensive approach, obviously being able to detect these things and be able to maybe suggest, if you're on a team, especially with a pain physician or physician who can prescribe medications, but also looking at, okay, what are the top-down influences of this condition as well? This person's got a limbic system that's really upregulated and in a more facilitatory state, and where we can maybe treat with things like pain neuroscience education, mindfulness strategies, different things like that. Where do you see like big picture treatment of these patients? Obviously some great things we can do for neurodynamic treatments and things like that, which are of course a part of the equation, but I'm wondering what you think as far as more kind of that whole, if we're thinking biopsychosocial lens of things. What do you think there, Joel?
That's a great question, and something that Annina brought up earlier. The pendulum is certainly, just like most things in medicine or physical therapy, the pendulum has definitely swung on this a few different ways, but it started with these initial injuries back when it was considered railway spine, when there was not even motor vehicle collisions, and it was purely psychosis. And then it swung to, oh, we shouldn't even consider that at all. It's purely a biomedical approach. And I don't think either are correct, right? More literature that's coming out, just like Annina mentioned with a fall from a bike. It's important that we screen for these things. It's common that psychosocial contributions are present after whiplash injury. Like you mentioned before, acutely, the strength of these as predictors of how you will do is a bit messy in the literature. There is a more consistent finding of hyperarousal or one kind of aspect of post-traumatic stress to be predictor of how you do later on, but it's certainly by no means perfectly clear. Some great work by Michelle Sterling and colleagues in Australia is one of kind of the strongest evidence that we have lately of a nice combined and balanced clinical approach. And that was published a few years ago, but basically they use a physical therapy exercise routine paired with the combination of stress reduction techniques and show much bigger effects compared to those that don't have the stress reduction techniques. And so that can look different for all of us clinically. I know they've established a way of educating clinicians about the specific interventions that they use. But I think even just from a bigger picture lens, taking that away is making sure that in patients that do have whiplash injury or have had these traumatic accidents, that we're definitely asking and screening for these questions to see if they are present. If they are, that might mean that in addition to the other beneficial services, exercise, manual therapy, other things that we can intervene on, that this also, whether it's in our skill set or another provider skill set, should be something that we should consider or that a person should receive if they are experiencing those symptoms.
Annina, anything you'd add to that as far as what is that well-rounded approach with somebody who's dealing with this?
Yes, I would absolutely agree with Joel says. And I actually quite like that there is different approaches, right, to look at patients, because already if we look at the Quebec task force, it's already very clear that this is not black or white, right? It's a spectrum of things that can happen to people on the biomedical side, but surely also on the psychosocial side, etc. So we have to just make sure that we look at individual patients, like Joel rightly said, very carefully, and try and understand in that person in front of us, what is the most important thing. Now, in research, that might also mean that we might have to be a bit more careful what kind of patients are we selecting to certain trials. Say, for example, should there be trials on neuropathic pain? You probably want to understand neuropathic pain interventions. You probably want to understand, is that specifically useful to those people who have mainly that component, right? Because it probably would not make sense to give that intervention to somebody with WOT2 that mainly has the more post-traumatic stress dominant mechanism. So I believe this will become quite important in the future. How are we looking at these patients? And I think physios are very good at that. In clinics, as researchers, we are still learning how do we best do that and how do we get around the problem of to make sense of different groups of patients in trials, etc.
Joel, I'm wondering what you think about mixed method studies. I know that's an undertaking and a half. I'm being not a researcher, I'm just a greedy clinician who wants all the answers and doesn't recognize all the hard work that goes into some of that. But I'm wondering what your thoughts are on mixed methods where we could have kind of the narrative of that patient unfolding qualitatively as we're studying some of these objective measures, especially when we look longitudinally at people and how they progress over time.
It's a great point. And obviously, as researchers, we want to try to do it all. And if we can look at it from every lens, but more and more kind of research organizations are emphasizing the importance of this. And so just like you said, we need to look at it both from a biomedical perspective. Our studies found things that hadn't been looked at in terms of nerve health and nerve pathology, but we also want to make sure that we're including a patient's voice and patient perspective, because if what we're researching doesn't match what they actually want better or want improved or need help with, then there's a big dissonance that we need to solve and make sure that we're both working towards a common goal. Like you said, pragmatically, these can be challenging to incorporate, but there's more and more great examples of how you can have a strong research objective that both patient and researcher are interested in, as well as researchers who have great qualitative experience that can help capture that experience and that patient's voice and perspective alongside that. So yeah, definitely no perfect answers to your question about the mixed methods, but just highlighting that the more that we can incorporate patient involvement and patient voices in our research, that everyone will benefit.
And I think you're seeing a bit of that, patient advocacy groups being more involved in journals and journals having more of an active kind of engagement with patient communities to make sure that voice is present. We've had some pioneers in that field, Gilletta Belton probably being one of the bigger ones here in the States, among other great folks in the UK and other areas of the world who have rightfully recognized that the voice of the patient has been missing from a lot of the research, but thankfully, again, it's being addressed. Annina, I'm wondering if you could speak to what questions you feel like are the biggest burning questions out there that you may already be tackling with some of your research, but I'm wondering if you could speak to where this goes forward from here when it comes to whiplash patients.
Yeah, so specifically in regards to whiplash, I do think we have to, well, one thing that I still would like to understand, is there any chance that this might have been pre-existing from injury? Because that our study cannot answer that. So our study looked within 4 weeks of injury, so nicely and acutely. But we, of course, don't quite know whether something has been pre-existing. There are certain reasons in our data why we believe it's not a pre-existing problem that tell us that. But to know that, we basically would almost have to test them probably immediately after injury, right? The day that they get into A&D or something like that. The other thing is indeed understand a bit better what kind of treatments these patients would benefit from. And is there specific subgroups of patients that would benefit more from this or that type of treatment? So that would be quite nice. In terms of the prognostic side of things, like Joel mentioned, we had a really interesting prognostic factor that came up in our work. That was that sum score of the hypoesthesia measures, the bedside clinical sensory examination that predicted a certain proportion, with a certain strength, whether people develop chronic pain. Now, if we would want to take that forward to a clinically useful tool, which it is not at the moment because this is a relatively small sample done in 2 centers only, then we would have to move that to a multi-center, larger study with much more people. So these are, I think, very logical next things. And then, of course, we are working on a few very exciting things as well, but we might not quite give these away as yet, maybe. Once we have published them, maybe.
We'll have to talk to you all in future episodes once you start letting us in on some of the great work you're doing. Joel, I'd love to hear what questions you're asking now. I know you're doing your postdoc over there in Stanford. What kind of things are you looking to answer and maybe move forward as far as our understanding of things around this?
Yeah, especially around this topic. My research right now is in a different population, but still building on some of the quantitative neuroimaging. So trying to look at what specifically both clinical MRIs, so that people get MRIs normally, as well as more advanced research methodologies for MRIs, what that can help tell us about both prognosis and mechanisms. Some great literature in the past has tried to dive more deeply into the mechanisms related to why people get persistent pain after whiplash. It's obviously just like the other literature in this area. It's very complicated when you have a big heterogeneous complex subgroups, but further trying to identify the actual biological mechanisms between what is happening. In addition to all the clinical points that Annina said, I think that's a really interesting and important area of research that we are working on a little bit, but that could definitely use much bigger, much larger, important studies.
Researchers seems to have us ask more questions, and things keep rolling forward. And I just wanted to respect both your time today and thank you both for all the work you're doing. I think you're great examples of folks who can wear clinical hats and also research hats and understand both sides of that equation. I think there's criticisms on that sometimes research doesn't land with clinical, and you're both good examples of folks who are translating it well to how this will hopefully impact clinical practice, and most importantly, how we're going to better help people who are dealing with whiplash-associated disorders. So thank you again for your time.
No, thank you for having us. One thing I would like to say as well, a massive thank you to all the team that has been involved in this research. So Joel has been leading a lot of it from the Oxford side, but in Brighton, that was Colette Reidhalt and Andrew Dilly as the principal investigators. So a massive thank you to them. And of course, to our funders as well that made this possible, because it's not a trivial study, and Joel can probably sing a bit of a song of how difficult it is to get this amount of people in for such detailed and extensive testing. So thank you as well to Versus Arthritis and the Medical Research Foundation UK that supported us financially doing this work.
Research for surely is a team sport, and you all have a great team. It looks like over there some great collaborative work going on, and thankfully more work to be done that will benefit from hearing from you all. For those of you listening, I would love if you could subscribe wherever you're listening to your podcast. And if you're watching on YouTube, we'd love if you could subscribe there. We will link some of the research and things mentioned in today's episode in the show notes, but we'll leave it there this week. We will talk to you all next week.